matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa...
Good morning, everyone. You may start settling down. We will be starting in 5 minutes. Again, you may start settling down. We will be starting in 5 minutes. Thank you.
Kalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan.
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. CERP is here for you. CERP is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies, government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access CERP, just visit the PIDS website and click the CERP widget under the Databases tab, or type cerp-p.pids.gov.ph. CERP has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, CERP has more than 60 partner institutions contributing knowledge resources to the database. CERP provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of CERP, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. CERP has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit CERP now. Socioeconomic Research Portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies, or PIDS, has been the country's foremost socioeconomic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through 3 basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month, or DPRM, held every September. To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies. Service through policy research.
Hello. All right. So, good morning, everyone, and welcome to the launch of the Health Economics and Finance program by the Philippine Institute for Development Studies. I am Dr. Chanel Dayan Mirafuentes, a researcher from PIDS, and it's my absolute pleasure today to be one of your hosts. Co-hosting with me today is my partner, Louie, whose name might ring a bell for some of you.
Hello, good morning, everyone. Some of you may already know me through the constant emails and reminders, but here I am now in skin and flesh. I am Louis Dagoy, a researcher from PIDS as well, and I will also be your host for today. It is a great honor to see each and every one of you gathered here as we celebrate a milestone in PIDS's history and begin a new era of this collaboration with our partners, the Philippine Health Insurance Corporation and the Department of Health, in the effective implementation of the universal healthcare.
Right, Louie. We've invited a lot of participants for this event from various organizations and disciplines. We have representatives from other the government agencies, medical professional societies, hospital providers, international and local development organizations, academic and research institutions, local government units, and of course, our friends from the media. This extensive guest list mirrors our belief that effective health reforms involve different
transportation, urban planning, climate change, contributing to national development and the well-being of all Filipinos. Most recently, our comprehensive evaluation of the Early Childhood Care and Development Program, conducted in partnership with the Second Congressional Commission on Education, deals with the amendment of the Early Years Act of 2013. One of the most significant policy milestones in recent years has been the passage of the Universal Healthcare Act, an unprecedented reform in the healthcare sector. While PIDS has been engaged in health financing research for over 40 years, we have intensified our focus on UHC over the past 5 years, recognizing that universal access to quality and affordable healthcare is critical to human capital development and sustained economic progress. Since 2019, in collaboration with the Department of Health, PhilHealth, and multilateral organizations, PIDS has conducted more than 30 health policy and economic studies amounting to a total of 150 million pesos. These studies have addressed key DOH programs, including the Health Facility Enhancement Program, the Health Human Resource Deployment Program, the National Immunization Program. Additionally, in 2022, the PIDS has been assisting PhilHealth in the transition from the all-case rate system for hospitalization to a more equitable diagnosis-related groups or DRG system, which incorporates prospective payment, global budgets, and predictable cost sharing for patients. Through these 5 years of close collaboration with DOH and PhilHealth on critical UHC reforms, we have learned that meaningful health reforms requires more than just research reports. It demands strong strategic and long-term partnership that translate knowledge into action. Research must not sit idly in the shelf, but drive tangible change in policies and systems. PIDS has established the Health Economics and Finance Program, is HEFP. I have to familiarize myself with the acronym VAL. As mandated by Republic Act 11975 and approved by the PIDS Board of Trustees in 2024 to further strengthen our contribution to the health policy and financing research. This HEFP represents our commitment to producing independent, innovative, and data-driven research, particularly in provider payment reforms and impact evaluations, essential to realizing the vision of UHC. More importantly, HEFP is an invitation to collaboration. Achieving UHC is not the work of a single institution. It requires the collective effort of implementing agencies, policymakers, medical societies, healthcare professionals, local governments, patient advocacy groups, development partners, and research institutions. The reality is that we cannot achieve UHC in isolation by researchers drafting recommendations from behind a desk. It requires engagement with real-world challenges, working alongside health systems actors to develop practical, context-sensitive, and actionable solutions. The launch of this HEFP marks an exciting new chapter for PIDS. We are eager to roll up our sleeves and work with all of you, our partners in research and policy, to shape real-world solutions that improve the healthcare delivery, enhance the financial protection, and ultimately lead to the better outcomes for all Filipinos. Thank you very much, and please enjoy the rest of the day.
Thank you very much, Dr. Orbeta, for those insightful opening remarks. We are truly rooting for the program's success as we've seen the Institute's contribution to national reforms over the years.
Now, it is my pleasure to introduce the next speaker, whose years of work as a public health leader, particularly in the fields of governance, human resources for health, and now policymaking, has elevated him to the position of Undersecretary for the Department of Health's Universal Healthcare Policy and Strategy Cluster. To deliver the keynote address on behalf of Secretary Teodoro Herbosa, let us give a warm round of applause and welcome Undersecretary Kenneth G. RONQUILLO.
Gandang araw po sa inyo. Isang pribilehyo na narito upang iparating ang mensahe ni Secretary Teodoro Herbosa. Masaya rin ho ako na nakikita dito mga dati kong mga katrabaho, mga mentors, mga kaibigan. So tama siguro na akong pinarating dito ni Sec Ted. And may just deliver his message. Dr. Aniceto Orbeta, President, Philippine Institute of Development Studies. Dr. VALERIE GILBERT ULEP, Senior Research Fellow and Program Director of the Philippine Institute of Development Studies. Dr. EDWIN MERCADO, President and Chief Executive Officer of PhilHealth. Our distinguished guests, health partners, ladies and gentlemen, a pleasant morning to all of you. Several decades ago, our Philippine health system stood as a paradigm of excellence for other nations to emulate. The period spanning the 1940s through the 1960s witnessed the implementation of groundbreaking rural health initiatives, the strengthening of maternal and child health services, and the establishment of the National Tuberculosis Program. Our nation confronted endemic diseases such as schistosomiasis and malaria while introducing an immunization program that triumphantly eradicated smallpox. These concerted efforts laid the cornerstone for a decentralized health system, later refined by the Local Government Code of 1991. While the Department of Health continues to orchestrate national health policies, the responsibility of healthcare delivery has been distributed across more than 1,000 local government units, a structure that, despite its merits, has introduced fragmentation into our health ecosystem. To address the complexities arising from devolution, landmark health legislation has been enacted throughout the years. The culmination in the historic passage of the Universal Healthcare Act of 2019. The National Health Insurance Act of 1995 established PhilHealth, while the Syntax Reform Law of 2012 substantially augmented the DOH budget. Though these reforms represented critical advancements toward a unified healthcare system, disparities persist, particularly evident in maternal and infant mortality indices, tuberculosis prevalence, and childhood stunting rates. In response to the enduring challenges, the Department of Health introduced Administrative Order 2023-0015, articulating our health sector 8-point action agenda. Sa bagong Pilipinas, bawat buhay mahalaga. This strategic framework builds upon the foundation of previous reforms while aligning with the priorities of the President and the current administration. Beyond the mere policy blueprint, it positions bawat Pilipino, bawat komunidad, at bawat health worker at institusyon. At the epicenter of all our interventions, our commitment is to ensure that quality healthcare remains accessible, equitable, and financially sustainable for all citizens of our republic. The strategic map envisions policy alignment and collaboration among stakeholders nationwide, aiming the Philippines to rank among the highest and healthiest nation in Asia by 2040. The UHC Act enables the crucial role of primary care, which also defines the initial contact, accessible, continuous, comprehensive, and coordinated care that includes a range of services for all presenting conditions. The Department of Health will implement primary care through 3 pillars: health promotion and disease prevention, acute care, and women's health. Today, we take another step that goal us to launch the Health, Economics, and Finance program of the Philippine Institute for Development Studies. The initiative is crucial in helping us navigate financing, and sustainably under the Universal Healthcare Republic Act 11975, enacted in 2023, mandates the UHC must provide strong financial protection for all Filipinos. But for these reforms to be effective, they must be guided by evidence-based policies. That is where HEFP will play a key role. One of HEFP's main priorities is PhilHealth reimbursement reform, particularly the shift to diagnosis-related groups. This system categorizes patients based on their conditions and treatments, ensuring fair reimbursements while improving efficiency and transparency. HEFP will also focus on healthcare financing and economics analyses. Right now, nearly half of our total health spending comes from out-of-pocket expenses, putting a heavy financial burden on Filipino families. Through research, we can find better financing models and policies to ease this burden and improve access to healthcare. At this core, HEFP will use data to generate insights that can guide better health policies. With PIDS expertise, we can ensure that our decisions are backed by evidence, leading to more responsive and resilient health systems. With this program, we will reinforce our commitment to making universal healthcare a reality. By strengthening research and policy, we can make sure that PhilHealth reforms align with our broader health goals and ensure that every Filipino has quality healthcare without financial hardship. On behalf of the Department of Health, I extend my profound gratitude to the Philippine Institute for Development Studies for spearheading the initiative, to our partners in government and academia for their support, and to each of you present today for your dedication in strengthening our health system. Together, let us redefine innovation and data-driven research for a healthier, sabi nga natin, bagong Pilipinas, hindi to sa speech ni Secretary, pero sasabihin ko rin sa inyo, dahil bawat buhay at idadagdag natin, bawat barya mahalaga. Maraming salamat po at mabuhay ang PIDS.
Thank you very much, Undersecretary Ronquillo, for that powerful address detailing what has already been accomplished, what else must be achieved, and how we can contribute in advancing the nation's health system goals with our respective capabilities and expertise.
Next, we are honored to hear a message of support from a staunch advocate of economic development through health reforms as the Secretary of the National Economic and Development Authority and the Chairman of the PIDS Board of Trustees. Let us give a warm round of applause for Dr. ARSENIO M. BALISACAN as we view his pre-recorded message.
My warmest greetings to you all. One of the most crucial pillars of a country's development agenda is building a productive. Strong economy generates more and higher quality jobs, fosters innovation, reduces poverty and inequality by improving access to education and human capital. Achieving and sustaining rapid inclusive economic growth, however, depends on robust health outcomes which serve as the indispensable foundation of economic progress. Research, including studies conducted at the Philippine Institute for Development Studies, PIDS, has shown that increased public health spending boosts labor productivity. Cross-country examples from ASEAN nations also highlight a strong correlation between higher gross domestic product, GDP per capita, investment in health, and improved life expectancy. However, persistent challenges continue to hinder progress. A recent PIDS report on early childhood care and development revealed that 1 in 3 children experiences stunting, while 9 in 10 struggle with reading and proficiency. These burdens limit their academic growth and future economic potential. Additionally, in 2023, out-of-pocket expenditures accounted for 44.4% of total health spending, underscoring the urgent need to address healthcare costs and expand access to quality, affordable services. Ensuring financial risk protection will allow households to allocate resources toward other essentials. Recognizing these challenges, the Marcos administration has adopted the 8-point action agenda aligned with the Philippine Development Plan 2023 to 2028 to implement programs that promote the health and well-being of every Filipino. A key component of this agenda is the continuation of reforms and investments under the Universal Health Care Act. Given the scale of challenges in this sector, the need for evidence-based health reforms has never been more urgent. Health policy research has always been a priority for PIDS, producing high-value studies that inform decision-making. The creation of the Health Economics and Finance Program, or HEFP, is a crucial step in addressing this need for high-quality research. It stands as a testament to the sector's importance and the commitment to data-driven policy making. Through HEFP's technical assistance, its partners, Department of Health and PhilHealth, can be better equipped to expand benefits, improve healthcare access, and enhance financial risk protection. The program also lays the groundwork for future collaborations with various agencies where research-driven insights lead to proactive, targeted, and impactful reforms. May the initiatives under HEFP serve as catalysts for social transformation in our pursuit of universal health care and a matatag, maginhawa, at panatag buhay for all Filipinos. Congratulations and good day to all.
Thank you, Secretary Balisacan, for your valuable support and encouragement. Your message truly strengthens our commitment to this program and highlights how the vital role of the health sector is for social transformation.
All right. Last but not the least, having had a professionally fulfilling career as both a clinician and a healthcare system executive, our next speaker now aspires to share his expertise to advance the UHC reforms as the President and Chief Executive Officer of the Philippine Health Insurance Corporation. Let's extend our gratitude to Dr. EDWIN MERCADO for his message of support. Let's give him a warm round of applause.
Hello. Isang magandang umaga po sa ating lahat. Una po ay good morning. I'd like to acknowledge, although online si Sec. ARSENIO Balisacan, President Aniceto Orbeta of the PIDS, USEC KENNETH RONQUILLO, ASVP, our acting senior vice president for our surge team in PhilHealth, who's in charge of drafting the primary care and also the HCPN, Dr. Clementine BAUTISTA. Of course, Dr. VALERIE GILBERT ULEP of the PIDS is also a part of our Technical Advisory Council or Technical Advisory Group. All the stakeholder representatives, muli isang magandang araw po sa inyong lahat. The PIDS and the PhilHealth partnership started with an assistance in benefit development and progress mainly in the partnership with the development or now being developed diagnosis-related group, which hopefully will redound or will result to a more fair and accurate payment system. I always believe that the payment system, that PhilHealth should use its power of the purse to change the behavior of both the patient and the provider, and also work with stakeholders like you to create the framework for benefit development and in coordination with our benefits development and research department. Our coordination has also extended to primary and outpatient care with the conduct of studies evaluating the preparedness of HCP and demonstration sites to adopt the provider payment reforms and outpatient and PhilHealth health insurance expansion as mandated by the Universal Healthcare Law. So we would like to shift from a checklist-driven local maturity level to one that is more outcome-based and process-driven. We are also awaiting the rules that will be set by the Commission on Audit on a prospective payment system, which we believe is the way to go, given that, again, it will change the behavior of the payer and the provider. Given that our strategic objective or strategic purchasing power will be enhanced when we now devise outcome-based studies for outcome-based metrics to give them some additional incentives. Now, the assistance from the PIDS has expanded on full-on health economics and finance program, which will provide consistent support through economic research and costing studies. We are actually engaging PIDS to come up with a study on what the next 10 to 20 most cost-effective health benefit packages would be, on top of the first 10 that was already drafted in coordination or in cooperation with an ADB study. We are shifting PhilHealth's direction towards a more value-based approach where we will prioritize high burden and high cost diseases. However, we can only identify these priorities through a rigorous studies and research. So right now, we are already shifting our payment our forms to what we call our ESOA, where we can now create a cost library and all the claims of the different hospitals will be structured. And we're also working with the providers, the HEFPs, the third-party providers, on how to make it very user-friendly. Because the usual problem is, number one, the doctors don't want to code their cases. And number two, it's very difficult to write their course in the ward. So I've talked to some of the HEFPs and they're willing to incorporate natural language processing in their software so that the doctors can just dictate the course in the wards and there would be drop downs for predictive coding when they do their coding. However, we can only identify these priorities through rigorous studies and research, as I mentioned earlier. This is where the PIDS will be most helpful, aiding PhilHealth to focus on services which will ensure the reduction of the out-of-pocket expenses. As was previously mentioned by Secretary Balisacan, we are hoping to lower our out-of-pocket expense from currently 44.4%, and this is the marching order given by our beloved President, to 30 to 25%, at which point the incidence of catastrophic financial risk is lowered significantly. We hope to harness the expertise of the PIDS to support our RISE mission. We just recently launched our 30-month agenda during the celebration of the 30th anniversary of the PhilHealth. We have our tagline, 30 months forward, 30 days at a time, where we hope to generate significant changes along 3 areas every 30 days. First area would be how to regain the member and provider trust. So just today, we announced the lifting of the 45-day confinement period cumulative for the whole year, which is an antiquated rule. And together with the 7-day readmission rate, it will provide more access to our members. Second area is the case of the ease of doing business or the ease of our operations. So we have 67 or 69, Dora always correct me, siloed IT programs in PhilHealth. And we're trying to consolidate along 4 or 5 buckets. And institutional strengthening. So the institutional strengthening, number one is through the appointment or the engagement of experts through the Technical Advisory Council. Sa pamamagitan nito, tunay nating may paparamdam ng PhilHealth ay para sa bawat bata, matanda, may kapansanan, bago pa man sila isilang. Sa pagsasaliksik na ginawa ng PIDS, ating matutuldukan ang dating daing at matutugunan din ang bagong hamon. As we know, providing social security and financial risk protection to Filipinos is a whole of society endeavor. With all the relevant stakeholders in attendance, we aim to have a deep dive discussion on our shared role in lowering out-of-pocket. Our intention is to work with the DOH on revisiting and recasting our target in the health financing strategy. For example, when we launch our Z package, my direction is to do a business plan more than an outright projection of 100% take-up. But that would also entail strategically aligning with the DOH program, or DOH providing the access, especially for regions without any Z package benefit provider. So with that roadmap, I think DOH through their HEFP, or the Health Facility Enhancement Program, can probably work with us on where to locate additional capabilities and equipment aligned with our Z package programs. For example, we'll be launching our Z package for additional cancer like liver, ovarian, and lung. And we're working also with the HTAC on making sure that the drugs that will be needed based on the evidence-based standard of care will already be facilitated. The launch of the PIDS's Health Economics and Finance Program will strengthen our collective capacity to reduce the financial impact of healthcare. Tutulungan po natin at pagtutulungan natin na mai-transform natin ang isang PhilHealth na mabilis, tapat, at mapagkakatiwalaan. At kailangan ko po yung tulong ninyo dahil napakalaki po itong hamon na hinaharap namin. Muli, maraming salamat and congratulations to the Philippine Institute for Development Studies on the launch of your program. Thank you very much po.
Thank you very much, President and CEO MERCADO. It's truly heartening, no, Chanel, to receive these messages of support from our client partners and from our officials from the Institute. It reaffirms our shared commitment to advancing this program and in highlighting the importance of data-driven reforms for a seamless implementation of the UHC Act.
That's right, Louis. The future looks promising for the health sector as HEFP will provide innovative research, providing evidence-based policy recommendations. But even before the inception of HEFP, the health team at PIDS has already been contributing to national health reforms with our research projects.
Now, to provide an in-depth introduction of the program, its purpose, accomplishments, and future direction, let's watch an audio-visual presentation which will be immediately followed up by a presentation from Dr. Valerie Gilbert to ULEP.
So Dr. ULEP, Val, is, as he's fondly called, is a civil servant. He is a senior research fellow at the Philippine Institute for Development Studies, and he currently serves as the program director of the Health Economics and Finance Program. Val has authored discussion papers, book chapters, and journal manuscripts on health financing, health policy, and nutrition. He provided technical assistance to governments and international organizations, such as the Center for Global Development, USAID, the United Nations, the World Bank, WHO Geneva, and the Asian Development Bank. Before joining PIDS, Val worked at the World Bank in DC and Delhi offices, supporting countries in the South Asia region to roll out UHC reforms. He was a doctoral fellow at the Center for Global Health Research at the University of Toronto, a visiting fellow at the Nikkei Japan Center for Economic Research in Tokyo, and a fellow at the Hopkins School of Advanced International Studies. He holds a PhD in health economics. So once again, please settle in as we begin with the AVP.
Getting sick is more than just a health issue. It's a financial burden. Out-of-pocket spending accounts for nearly half of health expenditures in the Philippines, making healthcare inaccessible for many. In 2023 alone, 1.2 million Filipino households face catastrophic health spending, sacrificing essential needs for medical expense, pushing them into a cycle of poverty spiraling them. The enactment of the Universal Healthcare Act aims to change all this. The Philippine Institute for Development Studies, or PIDS, is the country's premier think tank since 1977. PIDS has an expansive track record of promoting invaluable health sector reforms alongside the Department of Health and PhilHealth, spanning the last decade. A success that has since been formalized through a memorandum of agreement to further strengthen and sustain progress in the health sector. This progress has been borne out by dozens of studies that have directly led to improvements in the country's health system and health policy. In 2020, the PIDS health team provided technical assistance to the ULEP, revolutionizing the country's capital investment strategy. They developed a data-driven approach to forecasting the infrastructure and equipment to prevent disability. The country adopted the health facility development by virtue of presidential memorandum from 2006. The PIDS health team also conducted extensive research into child nutrition and early activity in the country. Their work shed light on the deeply rooted systemic inefficiencies and inequality at the root of chronic malnutrition. These revelations have been instrumental in pushing for educational reform in progress. By carefully combing through hospitals' financial statements and health claims, PIDS has been able to build a bigger picture of PhilHealth's role in hospital occupancy in the country. And for every time the government has rolled out the future public health initiative, PIDS has been there to explore and evaluate their effectiveness, a crucial endpoint for policy debate and policy reform. Recognizing health as the cornerstone of social and economic progress, the Institute has created one of the most used future. As the country continues to grow, so too should the health needs become limited. PIDS tries to be part of the solution with a health economic and finance program. Through the HEFP, the Institute brings the research expertise to bear on the problem of healthcare finance. The HEFP is founded on the conviction that sufficient and fairly comprehensive quality healthcare is an absolute must for all Filipinos. With HEFP, we are building a better healthcare system that delivers the promise of universal healthcare for all Filipinos. Sa pagkakataon, yan ang
Hello?
So good morning. I'm very delighted to see new and familiar faces, mentors, fellow civil servants, leaders in the private sector, patient champions, civil society, and local governments. So in the next 15 minutes, I will introduce a PIDS Health, Economics, and Finance program, explaining the rationale behind this initiative and discuss the activities to assist our implementing agencies, PhilHealth and the Department of Health, and move us closer to achieving the universal healthcare. You might be wondering why is PIDS a government think tank that covers a wide range of sectors from education, agriculture, infrastructure, tourism, now creating a research program focused solely on the health sector. Here, we provide 3 of the many reasons. First, the rising income levels. The rising income levels will increase demand for high-quality healthcare services. So the Philippines is projected to reach an upper middle income country by, now it's 2026, but it's supposed to be 2025, over the past 2 decades. GDP per capita has steadily increased, hence bringing greater expectation from the rising middle class. The middle class will demand better healthcare, higher quality services, more responsive care, and a more institutionalized and a less fragmented health system. Second, the government is poised to become the dominant source of health spending, and this will have huge implications for private providers. Public spending on health in the Philippines is rising rapidly. As income grows, so does the government's share in health spending, a common trend in health financing transitions. In many countries experiencing health transitions or health financing transition, including the Philippines. The shift is driven by public demand for UHC and a stronger political focus on healthcare. However, increasing government health spending comes with fiscal and political implications. Third, PIDS projections in 2022 shows a significant rise in non-communicable diseases driven by aging populations and shifting epidemiologic patterns. As life expectancy increases, healthcare system must adapt to manage the growing burden of chronic conditions. The shift requires reform in the care delivery system and the way we finance our health system when we shift to non-communicable chronic conditions, to ensure that the patients receive a continuous and comprehensive care throughout their lifespan. Primary care and integrated care models will be then the key to effective disease management. With these shifts, one of the many shifts, health has become an important political and economic agenda. These changes highlight the need for think tanks and research institutions like PIDS to ramp up health policy research, creating the Health Economics and Finance Program dedicated to ensuring health policies. Informing these reforms are evidence-based, data-driven, and robust. So the RA 11975 and the PIDS board's resolution were the legal mandates for creating the Health Economics and Finance Program. This became possible with the generous leadership of our president, Dr. Aniceto Orbeta, and the support of our board of trustees headed by Secretary ARSENIO BALISACAN. And we also thank our partners, UH and PhilHealth, for this support. HEFP prioritizes 3 research areas in the short to medium term. So number 1 is rethinking our provider payment systems. Second is health sector performance measurements. And third is strengthening the culture of impact evaluation. The ethos of the health, or the ethos of the of HFEP are the following. Number 1 is we aim to establish a more strategic long-term partnership with agencies like PhilHealth and UH. For PIDS, this type of collaboration, long-term collaboration, nurtures high quality and innovative research in lieu of like very sporadic short-term type of research. Second is it also give us the incentive to proactively address the technical needs of PhilHealth and UH at that very moment. Second, and I think this is very personal to me, the program should serve as a training ground for early career economic and policy researchers, cultivating critical mass of expertise for the country. So when we try to understand the secret recipe of many countries that successfully achieve universal healthcare, is actually investing in the back-end technical experts. And I think we want to do the same as we transition to an upper middle income country. With this commitment, we at PIDS dedicated health team to work on the program, bringing together more than 20 researchers from diverse backgrounds, including physicians, economists, data scientists, epidemiologists, and social scientists. and around 75% of them are women. So now I want to highlight, so I'm a feminist, so so that was a deliberate attempt. But now I want to highlight our first focus area, provider payment reforms. So there will be some technicalities as I go along, but I hope you understand. I think we need to explain the research focus. The first focus is provider payments. So I'll start with the perennial challenge that we always encounter. Out-of-pocket spending remains high, covering half of health expenditure and driving many Filipinos into poverty. And we've done many research on this at PIDS. I want to benchmark with, this might be controversial, I want to benchmark Philippines with Indonesia because we have many similarities. In terms of, Indonesia has a highly decentralized system like the Philippines, highly fragmented health financing system like the Philippines. We have so many financing sources, right? Supply side constraint because of the geographical challenges and the large private sector penetration. It's so similar to the Philippines. But Indonesia is experiencing a large decline in out-of-pocket in the last 10 years. While there might be facing some fiscal challenges that could be debatable, Indonesia has made significant strides in mobilizing resources for health, expanding benefits, organizing a painful fragmented system that we tried, and reforming provider payment systems, moving towards the DRGs. Another important problem is that PhilHealth declining financial leverage over hospital revenues threatens PhilHealth's ability to drive efficiency, quality of care, and patients' financial protection. Our analysis of PIDS hospital financial report, which tried to collect a lot of financial statements, reveals downward trend. So PhilHealth provider payment system faces some weaknesses. That's why we see all these outcomes. Number one is issues in costing practices. Second is payment design and rate setting systems contribute to the inaccurate payment rates, unpredictable healthcare costs, and institutional mistrust. And to patients, this leads to lower financial protection. So we are here to help solve the problem. So what do we intend to do? So the HEFP is committed to data-driven, independent research to strengthen the provider payment system. This includes developing and updating diagnosis-related groupings, partnering with PhilHealth to institutionalize better costing standards, and analyzing the potential impact of transitioning into diagnosis-related group as envisioned in the Universal Healthcare Act. Another key activity is conducting a forward-looking, every time I say forward-looking, they always like, but forward-looking researcher to support policy reforms under the Universal Healthcare Act. This includes exploring transitions to a global budget and analyzing claims data to perform business intelligence, assessing care quality, which is essential as we transition. So as you transition into DRGs and global budget, quality of care becomes more and more important. But we haven't really thought about it, right? So I think we need to start looking into this as we transition. Okay, most ASEAN countries or our neighbors' health system, Thailand, Indonesia, Vietnam, and Malaysia also, along with many European countries, Australia and the US CMS, are now using DRG-based provider payment system. So I want to explain a little bit about DRG because I think this is important. So let's look at a fair payment example under a DRG. So I will provide two examples. One, a healthy teenager, I should say, and his lolo who has hypertension. Both have dengue without warning signs. One, the younger patient, was treated at a level 1 hospital and recovered in a day, while Lolo required care at a level 2 facility with close monitoring to prevent severe dengue. Under the current ACR, both would receive the same fixed rates, 10,000 pesos. This is just a sample number for ICD-10 A97.0. However, under a DRG adjusted payments, based on case complexity, one case with no complication with DRG 1856 would receive 6,000 pesos, while Lolo with moderate complication, DRG 1856.3 would be reimbursed 25,000 pesos. In summary, DRG factors in risk-adjusted costs, considering secondary diagnosis, procedures, patients' demographics, length of stay, discharge status, and even newborn birth weight, grouping cases with similar clinical characteristics and resource needs. We also tried to understand the governance structure of how countries implement DRG. A clear governance structure is essential to DRG implementation. We propose a 5-step approach based on established systems worldwide. Payment rate calculations like the Thai Case Mix Center, the Germany's Institute for Health Remuneration, or Australian Pricing Authority can be managed by an institution, a research institution separate from PhilHealth and UH. The PhilHealth board with UH to set the policy direction for DRG as per the UHC law. Second is that PhilHealth will set a relationship with stakeholders so that hospitals, health professionals, and patients to ensure that DRG development is transparent and collaborative. Third, this institution takes the lead in doing data analytics and the grunt work, basically, and processing stakeholders such as the medical societies and academia's input. And this leads to a 4th step of reporting these back to stakeholders through an iterative consultations to adjust the rates. And lastly, PhilHealth will take into consideration the recommendation of this group. It's still up to PhilHealth, given its budget constraints and other political or economic considerations. Transitioning into DRG requires significant technical work, and when we were discussing this with our partners in the region, it is actually very complex. Transitioning to DRG requires significant technical work. Initial step, policy development, DRG adoption, and pilot calculations using PhilHealth claims data are underway. We're currently working with PhilHealth on this. However, key tasks remain refinements, recalculations, and consultations, which can only proceed once PhilHealth collects data from the new claim form 5. PIDS has already developed a version 1 of the DRG implementation manual for future adoption, but this could result into more refinements as we get more data, a better and clean data. And we want to thank the DRG experts and economists from the World Bank for helping us review the technical soundness of this. And obviously, our friends from the Thai NHSO. So collaboration is important for continuous progress in DRG, and that's one of the things that we've learned. Medical societies and academia validate clinical algorithms, while potentially healthcare providers participate in costing studies for us to have a robust understanding of the payment rates. Okay, so I'll move now into the second focus area of the program, governance. And I think this has been a challenge, right? Assessing healthcare performance remain a challenge due to insufficient data. And as researchers, you always encounter this, like, are Filipinos healthier in local government 1 or in local government 2? How much is the government spending in local government one, in local government two? And are there disparities across local governments in terms of these inputs? The same applies for healthcare facility and workforce distribution. And the theory of change here is that addressing these gaps could be done through improving accountability and resource allocation. So what do we mean by this? So how can we help on this front? So the program aims to independently generate data to inform governments, civil society, and the public. The PIDS team has dedicated, so out of the 20 researchers, the PIDS team had a dedicated data team that regularly analyzes health data from various administrative sources. And I kid you not, it's very fragmented. Apparently, it's very, very fragmented, and we try to consolidate them. And we conduct sectoral performance using these data at the local government level and plans to develop data visualization to a broader audience. Now, I want to discuss briefly our third focus area, which is impact evaluation. And I think this is my last slide. So PIDS, in general, promotes evaluation of government programs and projects, a priority backed by NEDA or DBM. So collaborating with agencies like PhilHealth, we've assessed, and many multilateral organizations, we've assessed key programs like Pantawid Pamilya, Social Protection Program, infrastructure projects, leading to policy improvements. So over the past 5 years, we've expanded this work to health, evaluation of the National Immunization Program, tobacco control programs, early childhood care programs, and capital investment programs. So in this program, we want to strengthen our commitment to evidence-based policymaking by continuing the traditions of evidence-based evaluation of its effectiveness. So I think this is my last slides, and I would like to thank again everyone for joining us today to launch the health financing and economics. Sorry. Health economics and finance program. So sorry. So thank you very much. Thank you.
Thank you very much, Doc Val, for that informative presentation. I think I can speak for the both of us, Chanel, that it really makes you look forward for the future of the health sector. Now that HEFP established a program that is dedicated in conducting policy research to advancing universal healthcare.
Yes, I agree, Louis. The projects of our team have assisted policymakers in materializing data-driven reforms. And now that we have HEFP, we're looking to provide the same quality of policy research for reforms on provider payment mechanisms. It is indeed an interesting future for the Institute, for our stakeholders who are with us right now, and those who are watching from our live stream, and of course, to our team. We're really excited with what HEFP has to offer in the future.
That's right, Chanel. But we must remember, Rome wasn't built in a day. So it's going to take some time for these reforms to materialize. And that is why we will be having a 10-minute break as well, to let everyone stretch and for everyone to eat their snacks, which will be served in a few minutes. The morning snacks will be served to your table shortly. Please fuel up with your foods, as we will have the ceremonial signing and the panel discussion after the break. So please, we'll see you all back in 10 minutes. Thank you.
Thank you, everyone.
Out-of-pocket spending accounts for nearly half of health expenditures in the Philippines, making healthcare inaccessible for many. In 2023 alone, 1.2 million Filipino households faced catastrophic health spending, sacrificing essential needs for medical expenses, pushing them into a cycle of poverty and spiraling debt. The enactment of the Universal Healthcare Act aimed to change all this. The Philippine Institute for Development Studies, or PIDS, is the country's premier think tank since 1977. PIDS has an expansive track record of promoting invaluable health sector reforms alongside the Department of Health and PhilHealth, spanning the last decade. A success that has since been formalized through a memorandum of agreement to further strengthen and sustain progress in the health sector. This progress has been borne out by dozens of studies that have directly led to improvements in the country's health systems and health policies. In 2020, the PIDS health team provided technical assistance to the DOH, revolutionizing the country's capital investment strategies. They developed a data-driven approach to forecasting the infrastructure and equipment needs of provincial health facilities. The country adopted this health facility development plan by virtue of Presidential Memorandum Circular number 26. The PIDS health team has also conducted extensive research into child nutrition and early education in the country. Their work shed light on the deeply seated systemic inefficiencies and inequalities at the root of chronic malnutrition. These revelations have been instrumental in pushing for educational reforms in Congress. By carefully combing through hospitals' financial statements and health claims, PIDS has been able to build a bigger picture of PhilHealth's role in hospital financing in the country. And for every time that the government has rolled out a major public health initiative, PIDS has been there to explore and evaluate their effectiveness, a crucial anchor point for policy debates and policy reforms. Recognizing health as the cornerstone of social and economic progress, the Institute has made this one of its priority research areas. As the country continues to grow, so too do its health needs become more nuanced and diverse. PIDS strives to be a part of the solution with its health economics and finance program. Through the HEFP, the Institute brings its expansive research expertise to bear on the problem of healthcare financing. The HEFP is founded on the conviction that sufficient and fairly compensated quality healthcare is an absolute must for all Filipinos. With HEFP, we are building a better healthcare system that delivers on the promise of universal healthcare for all Filipinos.
Sapat at tapat, yan ang dapat.
Dapat po munang alamin or matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga polisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan diin ng kahalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan.
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. CERPI is here for you. CERPI is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies, government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access CERPI, just visit the PIDS website and click the CERPI widget under the Databases tab, or type cerp-p.pids.gov.ph. CERPI has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, CERPI has more than 60 partner institutions contributing knowledge resources to the database. CERPI provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of CERPI, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. CERPI has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit CERPI now. Socioeconomic Research Portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies, or PIDS, has been the country's foremost socioeconomic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through three basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month, or DPRM, held every September. To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies, service through policy research.
Getting sick is more than just a health issue. It's a financial burden. Out-of-pocket spending accounts for nearly half of health expenditures in the Philippines, making healthcare inaccessible for many. In 2023 alone, 1.2 million Filipino households faced catastrophic health spending, sacrificing essential needs for medical expenses, pushing them into a cycle of poverty and spiraling debt. The enactment of the Universal Healthcare Act aimed to change all this. The Philippine Institute for Development Studies, or PIDS, is the country's premier think tank since 1977. PIDS has an expansive track record of promoting invaluable health sector reforms alongside the Department of Health and PhilHealth, spanning the last decade. A success that has since been formalized through a Memorandum of Agreement to further strengthen and sustain progress in the health sector. This progress has been borne out by dozens of studies that have directly led to improvements in the country's health systems and health policies. In 2020, the PIDS health team provided technical assistance to the DOH, revolutionizing the country's capital investment strategies. They developed a data-driven approach to forecasting the infrastructure and equipment needs of provincial health facilities. The country
Hello?
adopted this
Good
health
morning,
facility
everyone.
development
You may all
plan
start
by
settling
virtue
down
of
as we will
Presidential
resume the
Memorandum
program in
Circular
exactly 5
number
minutes.
26.
Again, you may
The
start settling
PIDS health
down. We
team
will
has
be
also
resuming the
conducted
program in 5
extensive
minutes.
research
Thank you.
into child nutrition and early education in the country. Their work shed light on the deeply seated systemic inefficiencies and inequalities at the root of chronic malnutrition. These revelations have been instrumental in pushing for educational reforms in Congress. By carefully combing through hospitals' financial statements and health claims, PIDS has been able to build a bigger picture of PhilHealth's role in hospital financing in the country. And for every time that the government has rolled out a major public health initiative, PIDS has been there to explore and evaluate their effectiveness, a crucial anchor point for policy debates and policy reforms. Recognizing health as the cornerstone of social and economic progress, the Institute has made this one of its priority research areas. As the country continues to grow, so too do its health needs become more nuanced and diverse. PIDS strives to be a part of the solution with its health economics and finance program. Through the HEFP, the Institute brings its expansive research expertise to bear on the problem of healthcare financing. The HEFP is founded on the conviction that sufficient and fairly compensated quality healthcare is an absolute must for all Filipinos. With HEFP, we are building a better healthcare system that delivers on the promise of universal healthcare for all Filipinos.
Sapat at tapat, yan ang dapat.
Dapat po munang alamin or matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga polisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan din ng kahalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan.
Hello, everyone. Welcome back. Before proceeding, we'd like to remind everyone of the evaluation forms. Kindly answer and submit it to a registration booth located outside. This event is being live streamed by the PIDS official Facebook page, so we'd really appreciate it if you could share this event, follow the Institute's official Facebook page, and mention the hashtag Sapat, Tapat, Dapat.
All right. So once again, hello everyone, and we kindly ask you to please start settling down. And we hope everyone has eaten their snacks as we move forward with the program. We will now proceed with the ceremonial signing, followed by a quick photo opportunity. May I now call on Dr. Aniceto Orbeta Jr., President of PIDS, Dr. EDWIN MERCADO, President and CEO of PhilHealth, Dr. VALERIE Gilbert ULEP, Program Director of HEFP, and Dr. CLEMENTINE BAUTISTA, Acting Senior Vice President from the PhilHealth UHC Surge Team. May we kindly request these individuals to proceed to the stage for the ceremonial sign. So as we wait for everyone to settle down, and also as we prepare for the ceremonial signing, Okay. So once again, thank you so much, everyone, for being with us here today. And we hope that the first half of the program has been informative for you in achieving the goal of advancing data-driven reforms through our newly instituted program. All right. So now now that our executives have come to the stage, we will now proceed with the ceremonial signing. So may we request a warm round of applause for the floor, and may we request our individuals to remain on stage for the photo documentation.
Again, let's please give them a warm round of applause.
So once again, congratulations to these two institutions, the PIDS and PhilHealth, as we reinforce our partnership in advancing data-driven UHC reforms.
We will now be having the panel discussion segment of the event. But while we wait for the staff to prepare the stage for that segment, we would like again everyone to please fill up and pass the evaluation form after filling it up. Now, moving on, I think we can share some few insights with the participants, right, Chanel?
Yes, that is, I think that's something we can do right now. So once again, we'd like to reiterate that this event marks an important milestone, as we just witnessed a while ago, especially with the launch of the Health Economics and Finance Program, or HEFP, here at the Philippine Institute for Development Studies.
That's right, Chanel. Again, HEFP is not just another research initiative. It's a dedicated program that aims to provide data-driven and evidence-based policy. And we all know that this is essential for effective health financing, and it's very critical in making universal healthcare a reality.
That's exactly right, Louis. And through HEFP, we are ensuring that the policies that our policymakers and our important government agencies they will be backed by solid research and informed by real-world data. This means that our recommendations won't just stay on paper. They are designed to help shape real, impactful reforms in how we finance healthcare in the country.
And that's true, Chanel. And the way HEFP does this is by providing technical assistance to the Department of Health and PhilHealth. These agencies play a major role in implementing the UHC Act. And with the right data and insights, we can help them navigate the challenges and improve health service delivery and finance.
Yes, that's a great point, Louis, because at the heart of this program is the idea that good policy comes from good research. By studying provider payment mechanisms, health expenditure trends, and financing models, HEFP contributes to making healthcare more accessible, equitable, and sustainable for all Filipinos.
That's very true, Chanel. And today's discussion, including our upcoming panel segment, will help us better understand the work being done in this field. We'll hear from experts who have been at the forefront of these reforms and get their insights on the next steps moving forward for universal healthcare.
All right, and that's exactly right. So, and we'd also like to remind everyone that everyone has an integral role to either formulating or implementing the reforms. So, for example, in terms of health governance, it will require more than the government agencies to ensure that these reforms are effective. And of course, collaborating with different stakeholders will allow us to really see if there are any systemic issues or inefficiencies on the ground that can possibly obstruct service delivery and make patients vulnerable to financial challenges.
And with that, we hope this discussion has given you more insight into the work we're doing under the HEFP. Now, let's check in with the preparations. And it looks like we're all set. We will now proceed with the panel discussion portion. To begin our panel discussion, let us call on the Program Director of HEFP, Dr. Valerie Gilbert T. ULEP, for the introduction of our moderator.
Hello, it's me again. So it's an honor for me to introduce our moderator for today, so Ms. Jana Uy. So Jana Uy is our supervising research specialist at PIDS and also serves as a program manager for health economics and finance program. So Jana has like 10 years of experience. She has authored numerous peer-reviewed journals on EPI and health policy. And one of her most significant contributions at PIDS was leading an important study on the financial health of hospitals and PhilHealth financial leverage. So using our large, intricate data of hospital financial statement, she was able to kind of understand the financial health of our health hospitals. So, but beyond research, Jana is a mentor to a lot of early career researchers and data scientists at PIDS. So encouraging academic rigor and excellence. So before joining PIDS, she co-founded Epimetrics, a research consulting firm supporting early care researchers in advancing impactful health studies in the Philippines. She holds a master's degree in epidemiology from the Harvard T-Chance School of Public Health. So, Jana.
So thank you very much, Dr. Ulep, for the warm introduction and slightly embarrassing introduction. So once again, I'm Jana, and I will be your moderator for today's panel discussion. And the objective of today's panel, can we flash the slides, please, to the audience? I'll just go it. So the aim of today's panel is really to explore the perspectives of our stakeholders on the value of data-driven research in advancing provider payment reforms. So as Dr. Ulep presented a while ago, there are many technical aspects of the reform. However, you know, the computer screen is not real life. And we really need the strong participation and ownership of our stakeholders in the policy making. Because at the end of the day, the people implementing these reforms are not us researchers sitting in our chairs, but the people at the front lines, in the hospitals and the clinics, the patients, the providers, and also the private sector supplying all our medicines and devices, right? Okay. So that's why today I am pleased and very honored to introduce our 8 panelists. I will start with Ms. Karen Alparcen Villanueva, the President of the Philippine Alliance for Patient Organizations. She is a former chair of the PhilHealth Benefits Committee, which she actually co-founded. For the past decade, she has been an ardent champion of patient rights, using her experience in communications and policy from the private sector to really give patients a voice in policy making through her various roles in international and local governance. Okay. And next, warm welcome to PhilHealth's Dr. Clementine Bautista, Senior Vice President of the Universal Healthcare Surge Team and a close direct partner of the PIDS in the past 3 years. So since 2022, Dr. Bautista has been leading her team in accelerating the accomplishment of PhilHealth's mandates for universal healthcare, such as the diagnosis-related groups and expansion of comprehensive outpatient benefit packages. Okay. Third, we have Dr. Maria Realiza Henson, Assistant Secretary General of the Philippine Medical Association. The PMA is composed of more than 200 medical societies and more than 30,000 physicians. Since she started her career in 1967, she emerged as an astounding physician leader, diligently serving her colleagues, the wider medical community, her patients, with sincere commitment and excellence. Today, she stands as one of the pillars of the medical community. Welcome po. Okay. Now, may we call on Ms. Lourdes Desiree Daisy Sembrano to the stage. So Ms. Sembrano is the Healthcare Policy Director of the Pharmaceutical and Healthcare Association of the Philippines, which represents 42 national and global pharmaceutical companies. And with her over 40 years of experience in the pharma industry, and after retiring from the GSK as the Vice President for Government and Public Affairs, she now spearheads collaborations with government and stakeholders, shaping policies that improve access to innovative and quality life-saving medications for the Philippines. Fifth, we have Dr. Manuel Francisco Rami Rojas, Chairman of the Philippine College of Surgeons Cancer Commission Foundation. She is also a clinical associate professor at the UP College of Medicine and Philippine General Hospital. He also serves as the Chief Operating Officer of the Healthway Cancer Care Center. So in his long career as a healthcare manager and surgeon exemplar in colorectal surgery in Asia, he has mentored many surgical trainees while advancing innovative and quality healthcare for surgery in the Philippines. Now, may we welcome Dr. Leonila Inday Dance to the stage. Okay. Dr. Dan was a full professor for over 4 decades at the UP Manila College of Medicine. As one of the pioneers of evidence-based medicine in the Philippines, she actually developed the first pediatric rheumatology fellowship training program at the PGH. And she led the first implementation of Southeast Asia's Masters in Clinical Epidemiology at the same institution. Okay? She has resolutely trained hundreds of clinicians and researchers in EBM in her career. Now, representing the hospital sector, may we welcome Dr. Jaime A. Almora, Vice President for Hospital Affairs and former president of the Philippine Hospital Association during the COVID era, where he helped, so in the Philippine Hospital Association, he helps lead and assist over 2,000 government and private hospitals in the country. So in this role, in his prior roles as the president of several medical societies, 25 years of directing the Almora General Hospital in Kalinga Province, and after starting out as a rural health physician, he really has continuously driven initiatives that enhance healthcare service quality and hospital management in the country. And finally, but not in any way least, we warmly invite Dr. Ricardo June Adriano Jr. to the stage. Okay, Dr. June is a director and former president of the Private Hospital Association of the Philippines. He is also a regent of the Philippine College of Hospital Administrators. In his remarkable career of lifelong learning, he has applied his various degrees and certifications in the pursuit of continuous quality improvement in healthcare. He has been key in actually increasing awareness of his member hospitals about the Philippine DRGs, which started in 2020. All right. May we give the panelists a warm welcome and round of applause. Welcome to the stage. All right. Now I will discuss the panel mechanics and ground rules. Next slide, please. So the duration of the panel will be 1 hour. The panelists will have 3 minutes to respond to a question thrown at them. And we will try to stimulate a conversation between all the 8 panelists. After which, if we have enough time, we will open the floor to audience questions. These questions will be curated because of the limited time. So if you have a question during the talk, please raise your hands. An usher and our host will come to you and ask you your question so we can record it for later. Okay. And then during these Q&A, we will have up to 2 panelists respond for up to 2 minutes. And then we will end with a summary of key insights. So we apologize for the unorthodox nature of this panel, that there are 8 people on the stage. So it's quite a challenge for someone who is used to the computer screen to have a conversation book. So please forgive me and grant us your indulgence because we just have really a lot of stakeholders we want to talk to. So, ayun po. All right. So again, I'll just reiterate the panel objective. Next slide, please. We will now explore the perspectives of our key stakeholders in the value of data-driven research for advancing provider payment reforms. All right. So I will throw the first question to our partner at PhilHealth, Dr. Clementine Bautista, to open po. So PhilHealth is transitioning to all these new provider payment reforms, from the all-case rate system to the DRGs and global budgets and cost-sharing even. So, Dr. Clem, how is evidence and data important to the corporation in transitioning to these provider payments and also mitigating any unintended consequences for the rest of our stakeholders?
Hi, Jen. So, as a national purchaser, we are supposed to be and envisioned to become the strategic purchaser of the country. And for us to do that, one of the key elements is that we have to have a good provider payment mechanism. As just to briefly tell the current problem of the ACR or the all case rates now, which is the main provider payment mechanism for the inpatient services. We have 9,000 procedures and conditions in that case rates. And it's very difficult for us to adjust those rates every now and then because of the volume. And also we also want to be, if we want to be fair, we in paying our providers, then we need a data-driven and evidence-based approaches to ensure that accurate and relevant information is collected and analyzed to determine the appropriate components of the payment mechanism. And and since now we are going into the DRG payment system, PIDS will be there and the data that will be collected will be important for us to help PIDS analyze this data to come up with the elements of the DRG system, which includes the base rate determination, the weight of the DRGs by determining its complexities, and also the adjustment factors that needs to be considered. So what is it then for the health facilities? So for the data gathering, this will help, as I have mentioned, to determine the case mix, the complexity of the cases for each DRG, and then the cost and the charge data that we also need so that we could come up with rational payment. So all of this would actually redound to have an effective and more acceptable rates to the providers. Since the data will also be coming from the providers, then we hope that all of this will be more acceptable to the providers. And since this will be analyzed statistically, then it will also give robust to the evidence to this payment reform. So for the physicians, we hope that also the professional fees will also be taken into consideration on how this will be rationalized. So data again will be collected to determine the appropriate professional fees. And of course, for the patients, what we want to achieve using this data is to address the financial risk protection. As mentioned earlier, the out-of-pocket expense is currently at 45%. So therefore, with the right costing and right provider payment mechanism, hopefully we can address and reduce the out-of-pocket payments of the members. If not totally, but at least for those that, for the others that will avail of non-basic accommodation, there would be some sort of predictability in terms of the co-payment for the patients. As to how do we make sure that we address the unintended effects, because this is not a perfect provider payment mechanism. There are unintended effects, and we can do this by doing medical audits and also monitoring the provider performance and giving incentives to those that are performing well.
Thank you so much, Doc Clem. So it looks like provider payment really affects a lot of actors in the healthcare sector. No? So the providers, the patients, the hospitals. So may I direct the next question to Dr. Almora? Dr. Almora, PhilHealth is going towards fair and sufficient payments in these new provider payment reforms. So how do these kinds of systems, if they become fair and sufficient, support the country's public and private hospitals in their operations, efficiency, and ability to deliver quality of care to beneficiaries and patients?
Our concern is not just fair and transparent, efficient system, but adequate and prompt payment of our reimbursement claim. That is our main focus. We do not expect a perfect system, because I don't think we can ever be perfect, but at least it should be efficient enough to allow us to submit our reimbursement claims efficiently, and in real time. It will be processed promptly, so that we will be given adequate and prompt payment. That is our requirement. Thank you.
Thank you so much, Dr. Almora. So in terms of adequate and prompt payment, I would also like to understand from Dr. Henson. So how does a successful provider payment system look like for you and your ability and your relationship with your beneficiaries and patients?
Yes, as you all know, the Philippine Medical Association is the umbrella organization of all physicians accredited by the Philippine Regulatory Board. It consists of 118 component societies in 17 regions. And we have under it are the specialty divisions, the affiliate, and the specialty societies. So the elected officers, execom as we call them, go throughout the Philippines, through all the regions, to talk to these physicians, to our physicians, of their mga hinaing ba at saka yung mga gusto nilang iparating sa mga regulatory boards. So, to sum up, there are one in clamoring that I agree with Dr. Almora, the prompt payment of their fees, and if possible, the payments should be for hospitals and the doctors should be separate, because as of now, PhilHealth gives the payment, reimburses the payment to the hospitals, and it is the hospitals who distributes this to the doctors. But we really don't know. They don't know. They cannot understand why they have to wait for sometimes 5 to 6 months before they receive their payments. So, if possible, we would like to request PhilHealth to separate the reimbursement payments to the hospitals from the doctors. Thank you.
Thank you very much. So the payment of the fees is a really big factor in allowing you to provide care to your patients po, no? All right. Perhaps we can also hear from the private sector po, Dr. June. If in your perspective po, what are your thoughts of these payment reforms in the future? How can we make payments fair for doctors? And also the transparency po in things like the data and how we can assist you in the corporate as HEFP and also the corporation po in facilitating and solving this issue.
Okay. I would like also to I represent PHAPI, but I am not the only representative in the group. I would like to recognize Dr. Mads Barrera. She is also from PHAPI. She is a member of the board of advisory. And with regards to the question, PHIC needs to establish a clear system for patient classification, set up a payment formula, and ensure data accuracy and transparency. PHAPI since 2007, 2009, had been doing orientation and awareness with regards to DRG to our member hospitals. So PHAPI is willing to be involved in the development of the patient classification payment formula and ensure data accuracy. So, however, there are a lot of challenges regarding this. So just to mention a few, in the patient classification, the DRG assignment, perhaps I propose or suggest to develop a robust system. This involves classifying patients into DRGs based on their diagnosis, procedures, and other relevant factors. Also, a use of a reliable grouper. Consider using an established grouper software or algorithm to ensure accuracy and consistent DRG assignment. Okay, and sorry. With regards to data accuracy, accurate coding and documentation are crucial for the proper DRG assignments. Consider severity adjustments, DRGs. With regards to the payment formula, establish a base payment rate. This is the foundation for calculating DRG payments. And assign a relative weights to each DRG. And these weights reflect the average cost of treating patients within that DRG. And of course, last but not the least, implementation and management training and education is needed.
Thank you so much, Dr. Adriano. Perhaps we can have Dr. Clementine Bautista respond po to the plans of the corporation with regards to maybe the shadow billing, and transparency in the data and methodology for the RGs?
Currently, we are supposed to start the shadow billing, but of course, we have just some difficulties in the IT system. But once this is fully rolled out with the DRGs, we want to determine the cases that are, the conditions of the patient, including the comorbidities and all the patient characteristics. So that will form part of the development of the DRGs. And then apart from that, using also the data from what we call shadow billing, wherein we have a different claim form, which actually collects data for us, which are not included in the current claim forms. These are all the diagnostics, all the the procedures and the diseases of the patient taken into consideration. We hope to also get as I've mentioned earlier, get the correct base rate and the correct weight for this, so that we can fully know how much we can pay the providers based on the data that will also be provided by the providers. So that the DRG also is envisioned to be implemented together or bundled with blended with the global budget, so that we will be determining also the amount that we will be paying the providers on an annual basis. And with enough data, we should be able to provide also global budgets. And hopefully this could be done, as they've mentioned, prospectively, and pay this in what we call front loading, so that this can also address the issue on the turnaround time for payment.
Thank you very much, Doc Clem. So all these reforms sound very complicated and technical, but at the heart of it, the point of all of this is for our beneficiaries and patients to have financial risk protection. So may I now turn to Ms. Karen to expound to us in all this technical jargon, how can we hear the voice of the patients and incorporate their needs in the system?
Thanks so much. Yeah, at the end of the day, the patients need not know about the back-end changes, right? At the end of the day, the patients would want their benefits, to avail of the benefits, and that the providers as well get the claims that they reimburse, so that there's no glitch in terms of availing of these benefits. Actually, PAPO has an existing MOA with PhilHealth, where we provide the patient's perspective in terms of not just benefits development, but changes such as this. I think what the patient groups can actually bring to the table is to look at, number one, a system wherein our participation can be institutionalized. So last year in the World Health Assembly, there was a resolution passed on social participation, which means that the community needs to be part of healthcare policy making and decisions. And so we've actually worked with not just PhilHealth, but medical societies in terms of participating in CPG guidelines, etc. What I'm saying is that we want to be part of understanding this system, because it's a whole systemic change, and there needs to be a lot of information that will be communicated as well to patients to help them understand during the time transition that there may be glitches in how this moves forward. And then, of course, also we're willing, and I told Dr. MERCADO already, we're willing to provide feedback, right? So we want a say in terms of quality standards and even accreditation, and look at a system wherein there's a immediate feedback loop regarding these services. So we've done that not just for the Z benefits, but all other new policies that come into play. But the ideal situation is we're part of the co-creation. So maybe involve us early on in the process and find a way to make it permanent so that even in the succeeding administrations, the voice of the patient is integrated already.
Ms. Karen, yes, stakeholder engagement really needs to be institutionalized in our processes. No? Para it's not just a top-down thing. Okay. In this regard, po, may I ask Dr. Rami? So in the Philippines, cancer is actually the second leading cause of mortality, and it's actually one of the most catastrophic diseases for our beneficiaries. Okay. As a physician, advocate, and healthcare manager, where you help Filipinos on their cancer journey, what should be the key considerations of the corporation, our researchers, the providers, when we do this process of inpatient and outpatient benefit expansion?
There's a lot to talk about now, but I'd like to focus on quality of care, which every Filipino should deserve. No? And there's I think President Mercado talked about value-based care on PhilHealth, and we know that the equation for value-based care is quality over cost. You look at the cost as an important component that PhilHealth will cover, but now we need to define quality, and quality is really good outcomes, and particularly in the cancer space. And cancer is a very complex disease. It's not one disease. It's many types of diseases requiring different types of specialists and medications and all. Quality becomes even more important. And from a clinical perspective, because I'm a clinician, we've had issues about quality. We see a lot of misdiagnosis. We see a lot of mismanagement that can happen. And so how do we show quality? I'll cite two examples that I think are successful. The first is the Z benefit for colorectal cancer, which I was a part of developing. The issue that was changing in colorectal cancer management then was you needed all sorts of modalities, surgery, chemotherapy, radiotherapy, and you needed the teams to work together. So what we put in place for the Z benefit was before the patient can be accepted the Z benefit, at least all three specialties had to weigh in and had a meeting. So this multidisciplinary approach. Secondly, PhilHealth was able to measure outcomes to the point that in PGH we came out with a paper that looked at not just compliance with treatment, which is an issue with patients complying, but also outcomes. And we saw under the Z benefit program increasing compliance with treatment and increasing survivorship of Z benefit. And these were the indigent patients of PGH, to the point that their outcomes, their survival, became international in effect. So that kind works. No? Of course, there are challenges with the Z benefit. You need to allow hospitals to be a little more flexible in the way they adopt it. I want to do more laparoscopic procedures for our patients, but you can't. The Z benefit can cover that. So to be a little more flexible in the way we do it. The other thing about quality is, and I learned this from the National Surgical Quality Improvement Program of the American College of Surgeons, where they measured and reported outcomes between hospitals and also between surgeons. And their basic hypothesis and conclusion was, if you measure quality outcomes and you report it transparently, that the hospitals and the surgeons can see where they are in that quality improvement, and then there's an automatic improvement in quality because everyone wants to do better. So you need that, and I think putting that together, that's what the DRGs and this PhilHealth reporting can do to improve quality.
Thank you so much. So data really drive. Data that is transparent and given to providers really drives quality. So Dr. Henson, you are very enthusiastic when Dr. Rami was talking. Would you have any thoughts about this driving quality in our providers and our hospitals for our patients?
Yes, the DRGs, the development of the DRGs are very helpful. It's, both to the hospitals and to the physicians as well. But then if these DRGs include the, as you all know, when we file a claim to the PhilHealth, we do a summary of all the what was done to the patient. The diagnostic procedures, some of the diagnostic procedures, and the medicines that are used to treat the patient are which are not in the formulary given to us by the PhilHealth, they will not be covered. So we would like to request, because they are specialists and they get updates every now and then. So the formulary in the PhilHealth, I cannot say that it's outdated, but the medicines that are used by these specialists are updated. So we would like to request the PhilHealth to consider covering for these medicines that are not in the formulary.
So it's really sort of the data will drive the flexibility and adaptability of the government systems. Speaking of medicines, Paul, Miss Daisy, how can PhilHealth and in your experience, Paul, how can we facilitate access to these life-saving and actually innovative new medications through provider payment reforms?
Too late. I will read my answer to the anticipated question. There is no universal healthcare without medicines, even vaccines and diagnostics. These technologies are the fruits of R&D efforts and have prior substantial investments and costs in churning them out of our pipelines, ensuring quality, monitoring outcomes, and continuing development of more innovative products. Appropriately, financing medicines incentivizes the R&D biopharma companies to strive towards sustainable innovation. So to facilitate access to innovative health interventions, what are needed are timely diagnosis and treatment, adequate and sustainable care financing, and support for managing the disease. Timely diagnosis and treatment commencement often do well in both achieving desired health outcomes and reducing long-term costs. That is why primary care, indeed, the first point of contact is the most important area of focus, yet also the most complex, given a broad range of players, including local government units. A health ecosystem needs to be in place to digitally capture real-world data, subsequently consolidated, monitored, and updated. Interoperability of digital platforms throughout the treatment continuum, from primary to secondary, tertiary, and specialty, across the facilities within the healthcare provider network is critical. And I have a wonderful, amazing experience with dengue. After I got in emergency care at the UP Health Service, I got confined at the lung center. 1 week after I got out of the hospital, the barangay people came to my house and fumigated. All right. So, but what was not captured by the health system was I also got myself vaccinated against dengue when I traveled to Thailand. So in acknowledgement of finite financing resources, data can drive to make address priorities. And the assurance of adequate and sustainable care financing does not just guarantee initiation of and adherence to prompt treatment, but also helps shape health-seeking behavior. We all know how many choose to present themselves for health checkups because they do not present themselves because they know that they cannot afford treatment. So an assurance will help them go for the checkups. And recently, while we learned that PhilHealth is looking at building a cost library for health technologies in order to inform benefit packages, we'd like to contribute to that, given accurate volume requirements that can be workable. Thank you.
Thank you so much. So it's really data, again, data for transparency, coordination, making the good decisions. So continuing.
Not disparate.
And not disparate. So it's a lot of data sharing, right? Not just from government agencies to us researchers, but also to fellow stakeholders, to each other. So continuing on this vein, may I ask someone from the hospital sector, maybe Dr. Almora or Dr. June, whichever who would like to respond. How does this data sharing look like for you? What would the hospitals also be willing to share with us, with each other, so that we can make this provider payment reform work for all of us?
The best data source for the payment of patient care is the patient clinical record. That is where all the services that is given is recorded, the medicines and all the procedures is recorded. So that is the best data source. And therefore, the best payment mechanism is the pay for service system. However, this is unpredictable for the actuarial computation. It is inconvenient for the for the fund managers in the preparation of the reimbursement. It is laborious for the evaluators, the claims evaluator. And this is the reason why we move away. This is our first payment system, the pay for service system. We move away from that system, but that is the fair and transparent system. But it is not the best system for PhilHealth because it creates delay in payment because it is very laborious. However, in the presence now of the AI technology, that is not an impossibility. As long as we have a system in the hospitals that is compatible with the systems in PhilHealth for a real-time submission of claims and human-free analytics of the data from the patient clinical record, that will be the best system, and it is not impossible. The DRG, however, is where we can, it's like the middle ground. It is convenient for PhilHealth. It is predictable for actuarial computations, but it is not really the best source of. It is not a fair and transparent system. It does not provide the best data source. Thank you.
Dr. E.
Yes, in response to the question about data collection and data accuracy of the data collection and at the same time analysis of the data. This is a very touchy issue with regards to private hospitals because many private hospitals, each private hospital has a different system. And so sometimes these systems does not talk to each other. And then once we deliver the data to PHIC, for example, there comes a problem with regards to the compatibility of the system. So that's one issue. Secondly is the protection of the data. So once the private hospitals delivers the data to the PHIC, for example, we have to be assured that the data is or protected in such a way that it will not be a source of perhaps violations with regards to the data privacy law.
Thank you so much. So there are real concerns about data security, data privacy, and the use of the data. May we ask Dr. Inday Dance? Sorry. We have so many po considerations and the complex realities po of stakeholder positions, no, and values. So how can the philosophy of evidence-based medicine, data-driven research really inform how PhilHealth navigates all these considerations po as it transitions to the new payment system?
Yeah. Okay. One of the misconceptions kasi when you try to promote evidence-based medicine, or like if you say data-driven kind of decision making, is that it's all about the data, it's all about the evidence. But in reality, in most situation, wala ngang evidence, di ba? So even in medicine, hindi naman kailangan may evidence. We decide based on not only evidence, importante that you explicitly look for evidence first, but you actually have to incorporate expertise. You also have to incorporate, values and preferences, both of the provider as well as the patient. And if you're going to introduce something new, something like the DRG, it's important to identify all the significant stakeholders to be able to understand what you're trying to introduce. The other thing is to be able to strategize. Just informing or telling us that there's a new system will not be, it's high risk for failure. So important to identify the right stakeholder, important to strategize how they can be informed and educated about the new system. And the other thing is to be able to identify conflicts of interest. Because if you're dealing with a lot of stakeholders who will have a lot of stakes in this new process, that can have an impact on the eventual outcome of the result of the new process.
So yes, so data is not the only thing, but it's really the people and their voices. So before I open the floor to the questions, maybe I can end with Miss Karen. So Miss Karen, the voice of the patient should really be at the center of all that we do. Perhaps you'd have thoughts for your fellow panelists in other sectors who are clinicians, hospital groups, and PhilHealth. What do you think the patient, the beneficiaries, what are your expectations for them as we move towards this reform?
So as I said earlier, at the end of the day, the patient would want to avail of the benefits, would want a reduction in the out-of-pocket expenses. For those who are not poor, predictability in terms of the costs, transparency in terms of doctors' fees, and the approach in terms of the entire continuum of care. So seeing the full spectrum that we are entitled to in terms of healthcare. And in fact, there's also talk about even hospice and palliative care already. So it sounds so simple, but it's not. And then also remembering issues of equity as well, making sure that as we transition towards this new system, hopefully not many will be left behind. And hopefully we'll also see a reduction in terms of medical assistance. It's very degrading to have to wait and ask people for support in terms of medical expenses to be detained in hospitals because patients could not be paid or be demanded deposit because they could not pay. So sounds simple, but it's not. At the end of the day, at the side of the patient advocacy groups, we're all also trying to build our capacity in terms of understanding all these changes that are ongoing. We want to be able to come with some knowledge when we're invited to either technical working groups or all these policy discussions. And so we've done a healthcare leadership and management course for 25 patient leaders almost 2 years ago. And we continue to look for these opportunities to build our capacity. We're also linked with global advocacy groups that also expose us to the developments in terms of UHC across the globe. We're part of the civil society engagement mechanism that is looking to track UHC, and the Philippines has volunteered and raised their hand to be monitored in terms of UHC implementation. So we're trying our very best to come prepared and to come with some knowledge. But we look forward to the other stakeholders here who may wish to connect with us and help us advance our capabilities to sit and engage meaningfully with all these policy discussions.
Thank you so much, Ms. Karen. So it's really bringing the patients along this journey of transition and policy making. All right, now that we have heard from our esteemed panelists, we can now open the floor for 3 questions. Chanel and Louis, please assist in
Hello, good morning, ma'am. Before stating your question, kindly introduce yourself, your affiliation, then proceed po with your question.
Good morning. I'm Gladys Martinez. I'm with Dr. Henson of the Philippine Medical Association. And I have different hats. I'm also with the Philippine College of Pharmaceutical Medicine. I have a question and a comment also. First, my question is to PhilHealth. Maybe the question regarding the data sharing is how granular does PhilHealth want, and what are the needed data that will assist you in determining costing for DRG? No? And then the other one that I heard is that there's interoperability. There's because you know, patient data, they are data entrusted to us, and we are covered with data privacy, right? So one of the things that we share in PMA and in all other societies that we engage in is that there are technologies. I already mentioned before the blockchain technology, because PhilHealth was then contemplating, are they going to do a centralized or decentralized? But the thing is, I think at this point, not only the IT people should be on the table discussing this kind of data sharing, but also the users and the originators. And that is what I get the sentiments from the people here. No? There's difficulty in the data sharing unless there is a clear data governance. And one of the things is that blockchain technology as a layer of technology over existing traditional or legacy systems, or even with AI and wearables, this agnostic technology is very adaptable. And for Philippines, because Philippines is a decentralized archipelago tayo, no? So those things, I think the blockchain awareness should be enhanced, and everyone should be aware about blockchain technology and how it can help in the ecosystem, lalo na with the data sharing. Thank you.
all right, Dr. Clem.
As to the data requirements for the DRGs, what we intend to collect, first, of course, we need the cost data, which is in the form of the SOA, or the statement of account, wherein in there we have all the services now provided by the hospital and the charges. And apart from that, we also need to get all the procedures done on the patient and the comorbidities, no, related to an episode of care, or related to the condition of the patient. Because currently our claim system only with the ACR, we only get up to 2 conditions, no? And we want to expand it to know, because one of the things that the DRG is, the advantages of having a DRG is that we will have to consider all of the comorbidities of the patient in coming up with the appropriate payment. And also, apart from that, there would be times that we would need the clinical abstract if we want to do quality audits. And we also intend, as mentioned by our colleague here, is to also we want to come up with a price library so that that's why we need the collect the SOA, and this would come from the SOA, no, or the statement of accounts or the itemized billing from the hospitals.
Thank you so much, Dr. Dr. Mads Valera.
Good morning, Mads Valera po. I have a comment and a question, but some of my questions were already answered by Clem. And I'm happy that Clem is the one heading the DRG. Dalaga pa yan, inumpisahan na namin ang DRG. Way back in 1999. Nasa college na yung kanyang anak ngayon. But, you know, I'm thankful that PIDS and PhilHealth resurrected the DRG. We started DRG in 1999, even before 1999, when we were working on the National Health Insurance Law, 1995. So way back, 1990. So hindi po ito bago. DRG, global budget, is not a new concept. Okay? I just want to understand, let everyone understand, there are tools and steps in the development of DRG. The first Philippine DRG was developed in 2009. What happened? It died a natural death? Or it was still it's still in comatose? We spent money to develop it. A lot of international agencies supported it, but we cannot implement it right away. Why? Because we have to first make sure there are proper coding system. We have to teach providers how to code. ICD-10, now ICD-11. Sino po ang magiging in charge diyan? I want to find out, sino po magiging in charge in training providers or making providers understand ICD-11? Quality improvement. Top-to po yun, Dr. Rojas. Kaya po may bench book. Ngayon, bench book 1, 2, 3 na ata, hindi ko na alam. Kaya lang po i-implement yun. Kaya lang po ituturo yun. We also need to have costing data. Nasabi na po ni Claire. We've been looking at costing data as early as 2000. I just hope there is really a continuity on this. I think to implement this, we really need to have a strong governance within PhilHealth and within BOH. I'm already 68. I hope it will not, kasi ilang beses na putol-putol. You know, in 2009, tapos pinangako 2005, tapos 2010, 2018, 2025 na po. So I hope it should be clear sino po ang gagawa ng mga tools or yung mga ingredients to come up with the DRG cake. It's not only PIDS. We need everyone here. And we do hope that it will be clarified as soon as possible so everyone can join in the baking of the cake. Thank you.
Thank you so much, Dr. Mads. Yes po, no, PIDS should not and will not monopolize this system kasi it's a joint effort by everyone.
All right, we have a question from table 15. Sir, can you introduce yourself?
Hi, so thank you for a good presentation from the panel. I'm Benjo Del Armente, health economist and general physician, most recently from UCLA, Value-Based Care Research Group. Just a comment and a question. First, I'd like to also build on the comment of Dr. Mads on quality. So I think Dr. Ross is correct in saying that like quality metrics can influence the behavior of physicians. And I think there's a big opportunity here with the claims data because there are and the data sharing because there are like claims-based quality metrics that can easily be implemented. And I think what's important also is to be transparent, like have a dashboard that's easily available and easily viewable, interpretable by patients, so that they can see, okay, which doctors are, have a 90% readmission rate and which ones have like a 10%, readmission rate or what have you. And the next, I think our colleague from PhilHealth already touched on this, on the issue of prices. I think the prices, I think, is something that's not as is sort of a bit missing in this equation. So while we do costing, right, and once the TRGs are developed and based on costing data, if prices, especially on some on the provider side, keep on rising, then the percentage of financing covered by PhilHealth, even if it's costed out, is still going to be low if there's no look on pricing. So in short of regulating pricing, price transparency is also important. So in the States, there's already a law that hospitals should post a computer readable list of prices. And I think that's something that could be done here in the Philippines as well. And then for risk adjustment as well, another comment, I think in addition to your usual metrics for risk adjustment, I think there should also be some thought on social risk adjustment. So we always talk about social determinants of health, and we know from studies on health disparities and health equity that lower income patients, have higher rates of readmission, higher rates of mortality, and what have you. And I guess my question would be, so I'm a researcher, and I'm an academic researcher, and my question would be, I guess, for PIDS and for PhilHealth, what is the thought regarding data availability for researchers? Like how accessible will the data be? Like in as much as there's a lot of brain power with PIDS, I think there's a lot of opportunity for to involve researchers. And not only on the costing side, but even the admin and the claims data can be powerful for epidemiology purposes. You have residency programs requiring research. So instead of some of these like doing, retrospective chart reviews, why don't we make them available for, for researchers? So like Medicare, for example, while they do their own Medicare in the US, while they do their own research, they make years of data available for researchers. And I think I'm just wondering what the thought is about that aspect from both PIDS and PhilHealth. Thank you.
Okay, so we can start with Dr. Bautista.
As to the data sharing, I think we don't have a problem with that as long as we follow the data privacy law. We actually have provided several data for several research institutions or students doing their own researches. They just have to request from PhilHealth for the exact data that they need. They have to actually identify what those data that they actually need, so that it will be easier for us to process, because our database is so big that it actually takes time for us to extract those data. And and of course, the data that we will be sharing is of course subject to the data privacy law. And that's it. And we really share naman data to researchers.
So from the side of PIDS HEFP po, I'll reiterate po the presentation of Dr. ULEP that actually the dream of the lab is to make data available and useful to all stakeholders. So we are actually planning a website. This is the dream po, where we have dashboards that that already have the analyzed data. So for example, po data from the Bureau of Local Government, which is public, that is health financing data from the LGUs. So the things that we can put publicly, we would like to, para it's available to everyone, especially beneficiary groups, hospitals po. On the other side naman po, we are also a frequent requester from the PhilHealth po. So the TFI and IITMD divisions must be sick of us. Because we are requesting all these data sets so that we can create the policy, parang support the policy decisions of PhilHealth for how much global budget should be, how much the rates should be. So things like that we cannot base on thin air. So this is why data transparency is really important to us. But also there's a big responsibility on our end to really secure the data. Such that syempre it does not leak and we comply with the Data Privacy Act. Okay? So actually this is an interesting conversation. I would also like to maybe redirect the question to Ms. Karen. So all this time we've been talking about the data important for the researchers, for the hospitals, but how is it important to the beneficiaries? And what do the beneficiaries want to see from not just researchers, but PhilHealth, providers, private sector, so that it can really help the patient journey?
I like the point raised by the gentleman on in terms of informing patients regarding outcomes of not just the providers, but the doctors themselves. No, we've been dreaming about this for many years now. It's similar to your TripAdvisor rating of health facilities and providers, because then there will be an incentive as well for the healthcare providers to be able to look at quality and, more importantly, patient safety as well, which is a huge concern. And the other point that I wanted to raise is the issue of medical inflation, also raised by the gentleman, and the fact that because of the rising medical inflation, even if PhilHealth increases their rates by 80%, 100%, if there's no cap in terms of the costings by our healthcare providers, then it's going to negate the benefits that PhilHealth will be providing. We understand that the private sector needs to make money, but is there a way to be able to how do I say this nice? Is there a way to be able to address the issue of inflation? Everybody raises, hell when the prices of rice goes up, but nobody's talking about the rising costs of medical services.
Perhaps we can get a reaction or a comment from Dr. Almora or Dr. June.
The biggest determinant of prices for medicines and supplies is the expiration date. So the supplier, the price of from the supplier is not fixed. It is labile, it is liquid. The nearer to the expiration, the cheaper is the price. So most of the supplies and medicines has a 5-year expiration date. So if you get it 5 years before expiration, then they will give you the full price. But if you get it 2 months before the expiration, you can even get it for free. So it is a very labile pricing, and that is the reason why we can never fix a price for medicines and supplies, because the price of supplier is dependent on the expiration date.
So maybe we could go with Ms. Daisy first and then Dr. Rami.
Sorry, sir. We're not allowed to sell drugs that will expire beyond 12 months. And the shelf life will actually depend on the studies conducted on the integrity of the medicine formulations. And we most certainly do not base our pricing on expiry date, at least not the PHEFP members. But what I wanted to highlight is we were worried, we were alarmed by 44.4% out of pocket for healthcare expenses in the Philippines. You'll fall off your chairs to find out that for medicines, out of pocket is actually 85%. That was in 2018, based on World Health OECD study. I don't know if the number has dropped. I sure hope so. But 85% among the highest in the world. And definitely healthcare financing of medicines is necessary. But we hope that financing is going to be based on need rather than policies. Okay, thank you.
Thank you so much, Dr. Ran.
I'll talk about one aspect of controlling costs, and it's tied in with quality assurance also. One of the principles of quality, one of the the one strong evidence of quality also is high volume centers and high volume physicians actually have better outcomes than those that just do it once in a blue moon. And if you tie that in with the Indian experience of high volume procedures, whether it's heart or eye operation, all, the more they do, they're able to package like a factory these costs together and therefore provide high quality but low cost procedures. We've tried that with the cancer hospital that we set up with Ayala, and when we started our first procedures, it's very hard to package because you don't know what they cost. You have to make emergency purchases, and therefore the initial costs are surprising even to the doctors. But the more these procedures come in and you're able to know which is the best type of drug, how to control the outcomes and all that, then packaging and control of costs become very important. So that's I think something that has to be stressed. High volume centers are important in trying to decrease the costs of some of these procedures.
Ms. Daisy, you have a follow-up?
I totally agree. Volumes drive prices down. And yet, given the fragmentation of the healthcare system, the new Government Procurement Act actually offers provisions and options for hospital groups, for example, to do pooling of their volume requirements so that they can negotiate better prices for supplies.
Maybe Dr. Henson, you were nodding your head if you had any thoughts about
Yes, I agree. We cannot control the prices of all hospitals, of all service providers, because as our colleagues have elucidated, prices are dependent on the volume of patients, on the volume of procedures done on patients, than on the supply. So that maybe in our institution, in my own institution, they tie up with other hospitals so that they can keep their prices reasonable. So I agree.
Thank you so much po. Perhaps we can have a reaction or a comment from the private sector po, Dr. Jude, if you have thoughts po on this matter.
Well, pricing is really a very difficult multifactorial thing in hospitals. So I think volume really help lessen the price, and as well as the quality of the physician who does the procedure also can lower the price. However, there are other factors to be considered because the pricing of medicines, for example, kind of varies depending on how far you are from the source of the medicine, for example. And then also it varies if it's an emergency purchase, because when you do emergency purchases, the price is higher compared to the regular way of purchasing. So it's a balancing act. And what I can say is some members of PHEFP, especially in the provinces, are having difficulty with regards to how they would price the supplies. Thank you.
So there are various factors that affect price. So while we can predict some of them, there are really some others that are really hard to control. Is there another question in the audience?
Yes, I have a question from table 5.
Morning, I'm Dr. Gap Legaspi from PGH, from the trenches of healthcare. Out of pocket during our time, I see old clinicians here during our residency time, included the pockets of residents and students, right? So as a public health practitioner, I've seen the progress of financing and how much more we can give to patients now. Unbelievable. I never thought I'd see it in our lifetime. But of course, being the servants that we are of public care, we want to improve more. And I'm really happy to see all of these post changes driven by data. I think I just want to ask, I don't know who will answer it. I'm happy that the president and CEO of PhilHealth still here, my classmate. I just want to ask, does the initial data that we have show that we can afford this? Can the government actually afford all of this decreasing out of pocket for our patients while maintaining quality also? So does the initial data show that?
So I think I have to answer this question po, no? So we have piloted actually the DRG calculations for last like 2 years ago, and we presented this to the World Bank and the Thai Case Mix Center. However, we used old data, and so the weights were kind of wonky. But at least they followed some logic. So we just tried it out. We simulated what is the financial impact of the DRGs to hospitals, individual hospitals even, groups of hospitals like level 1 public, level 2, and also PhilHealth. Okay, so if I use a base rate is sort of the parang relative weight equals 1 sa DRG. Parang kung relative weight equals 1, say 2,000 pesos yung base rate, yun po yung babayaran sa hospital. So if I follow medical inflation, just following medical inflation, by checking the average charges of hospitals, and I use that as the base rate. The base rate was around 20,000 pesos in 2019 data, and then it was 50% plus inflation, around 34,000 pesos in 2023 or 2022 data. If I just use that po, PhilHealth for those claims na old data would have to double their inpatient budget po to pay at the charge rate, at parang what hospitals charge. And then what happens is a reallocation, redistribution of the reimbursement also. So certain cases get more, certain cases get less because they're less complicated. So the general shift is the more complicated cases get more reimbursement, while the less complicated cases get less, because that's how the system works. Then the clear winners for parang reimbursement greater than charges of PhilHealth, yung parang there's a certain profit, is really lower level private and public hospitals. So I saw numbers, but these are all drafts po. These are all based on old data. Caveat lang po. We see around 80% of FRP, financial risk protection. For some cases that are really less complicated, you see total coverage for the charge. But if you just follow the inflation rate po, which we do not really advise po, because you will just keep increasing the medical inflation po. But the sort of, if you could say, losers, na medyo mababa po talaga yung financial risk protection coverage of charges is higher level, private level 2, level 3 hospitals. Because they handle the more complicated cases. And the data back then, the data we have for the old claims form does not really support us checking the complexity of the case. So that's why they kind of lose kasi the old data does not support the calculation of the correct relative weights for the DRGs. So that's where we are. Dr. Rami, you have a comment?
Can I add something here in my own perspective? And this has been pointed out by even the DOH secretary. You're right. The financing has improved, and indigent patients can get free care and good quality care. And the problem is the middle class, who pays for their PhilHealth and still don't get much of it is out of pocket. And unfortunately, the cancer space, you see that more. They all run out of their PhilHealth funds, and they end up paying out of pocket because of the expense of cancer treatment. And we can't deny also that cancer treatment, there's so much innovation. The immunotherapy drugs are so expensive, but you can see outcomes. I've seen stage 4 patients live longer. And to deny Filipino patients that innovation, of course, it's not something we should allow. And so the big help that we also see, but it's limited, is HMO. So in my perspective, if we cannot afford, if PhilHealth can afford it, the HMO industry is also an important part of trying to limit out-of-pocket services. But what are we doing with the HMO industry? And I'm not sure what that answer is because doctors are unhappy with HMOs, patients are unhappy with our HMOs. I think there are some doctors that even don't want to do HMOs, which is sad because that shouldn't be the case. Patients deserve to have HMOs also. So just a point I want to bring up. Let's not forget the HMO industry if we want to talk about decreasing out-of-pocket expenses for patients.
Dr. Clementine Bautista, if you would like to follow up.
So part of the determination is that, of course, not all patients or PhilHealth, not all of the cost can be shouldered by PhilHealth. And in accordance with the law also, for the fringe benefits, it's not mandatory for PhilHealth to cover this. We only cover the essentials. So there would be some cost sharing for some patients. And I think that's where the complementation with HMO will come in. There's also an ongoing work with ADB on the complementation together with the Insurance Commission and all the HMO groups. So that we are also talking and about how to complement the PhilHealth benefits so that again, the goal is to also decrease the out-of-pocket payments.
Okay, last.
Can I just add that on top of private HMOs, there are also other government funding support available. For instance, the MAIFIP from the DOH, others also the PCSO, the DSWD. We just wish there was a one-stop shop for all of that. The cancer law provides for the Cancer Assistance Fund.
Thank you very much. I think we do not have any more time. I'm sorry, sir. You can approach for panelist later po. So now I will end the discussion with a synthesis. So flash this time. I don't know. Okay. Sige. So I'll just summarize all the insights from the discussion from our panelists and from the Q&A. Okay. So data-driven policy research for universal healthcare really has far-reaching impacts that affect all our stakeholders, from the beneficiaries at the center to the doctors and hospitals who provide the care, the clinicians, and also the private sector who has a big role in supplying and producing the medications and the innovations in life-saving technologies, right? So at PhilHealth, HEFP, and with all our stakeholders, really envision strengthening accurate and transparent data collection, a semblance of data sharing that democratizes data use and analysis, so that we can inform strategic purchasing that is fair, prompt in payment, prompt in service delivery, responsive, and of good quality. And in this process, we want to ensure that all our stakeholders have a voice in the policy making. It is not just us academicians or policymakers in the central office doing all the decisions when the real impact is seen with the implementers and the beneficiaries. At the same time, the center and the telos of all of this is really providing quality healthcare to our beneficiaries without undue financial risk, and also for our stakeholders, hearing their voices, their inputs, and upholding the data security and privacy issues that we have. Okay, to achieve this intersectoral collaboration between all of us is important. Numbers are just numbers. They reflect real people facing real challenges on the ground and often scary, life-changing diseases. Okay. We should also remember that while we prize evidence and data, it's really the voices of the patients and our stakeholders who should inform everything at the end of the day. So we can design all the simulations, but the computer is not really. Okay. So evidence and research are only valuable insofar as they produce tangible and felt improvements in our stakeholders and ultimately health outcomes for our fellow Filipinos. Okay. So with that, we thank everyone, our esteemed panelists, for their time and sharing their expertise. And Miss Karen for supporting me on the side. And the audience for gracing us with their presence and also their discussions. Actually, I enjoyed the question and answer more than the first part. Thank you so much. Oh, thank you.
May
Okay, I
we
will turn the
may we
floor.
request our panelists to stay on stage for a moment for a photo documentation? Okay, so once again, thank you so much to our audience for your enthusiastic participation. Unfortunately, due to time constraints, we cannot entertain any more questions. However, there will be a link. Sorry, may we request the link to be flashed again? Huh? So if you still have questions for our panelists, you may visit this link bit.ly/HEFP questions. And then we assure you that we'll get back to you on them. And then for the presentation materials, you may get a copy from the PIDS website. So www.pids.gov.ph/event.
Again, quick reminder, the event is being live streamed at the official Facebook page of the Philippine Institute for Development Studies. So please go ahead on over to the Facebook page of PIDS, share the post, and kindly use the hashtag Sapat Tapat Dapat. You can also follow us in our different social media accounts on X, or formerly Twitter, and as well as on YouTube. Thank you, and please follow. We greatly appreciate the follow and sharing this with your colleagues.
All right. And once again, just a few reminders as we approach the close of the program. We'd like to remind everyone of the evaluation forms. Kindly answer and submit to our registration booth located outside. So these will be the reference for your certificate of appearance, which you can submit after submitting the feedback form.
May we request everyone to please settle down?
So once again, may we request everyone to settle down. We are nearing the end of our program. All right. So again, to end our program, our last speaker has served as a key figure in the development of crucial initiatives for the realization of PhilHealth's mandates according to the UHC Act. May we request everyone to join me in warmly welcoming Dr. Clementine Bautista, Acting Senior Vice President of the UHC Surge Team, to deliver the closing remarks.
Good afternoon, everyone. First of all, I'd like to congratulate our colleagues from the PIDS, the Philippine Institute for Development Studies, for the successful launch of the Health Economics and Finance program. But actually, at this point, we've already had several meetings and engagement with PIDS now for almost 2 years. And so I've actually known most of them, and such that I'd like to thank them also, especially the team that's working with and being led by Dr. Val ULEP. No, they're very dedicated and brilliant people, and they are very motivated and driven by their goal to contribute to the reforms of the country. So I hope most of them will keep working with PIDS and to, of course, to help drive all these reforms in the country. So the launch of this program is significant milestone in our collaborative efforts towards achieving universal health care for all Filipinos, particularly through data-driven and evidence guidelines on policy directions. Throughout this event, we have heard many insightful discussions on the initiatives that lie ahead for the program. As we know, data-driven and evidence-based research is paramount in guiding the development, the implementation, and evaluation of the provider payment reforms. And this is to ensure that these are responsive to the needs of our stakeholders. And we are certain that this program will further enable our policymakers to make informed decisions, which will ultimately improve access to healthcare services and the eventual reduction, if not elimination, of the out-of-pocket expenditures. So over the past years, the PIDS has continuously provided invaluable technical assistance to the Philippine Health Insurance Corporation as we navigate through the complex landscape of healthcare reform, including our transition toward diagnosis-related groups, or the DRGs. The shift to the DRG system represents a fundamental change in how we manage and finance healthcare services. Hence, this reform demands a more robust understanding of the health economics, finance, and data analytics. This shift from the current provider payment mechanism to DRG system is not without challenges. But of course, with the collaborative efforts, expertise, and dedication of our healthcare professionals, policymakers, researchers, and of course, our stakeholders, we can achieve more efficient, equitable, and sustainable healthcare system. We are confident that the program will also help numerous sectors, agencies, and organizations yield tangible benefits geared towards making healthcare more accessible, available, and appropriate for all Filipinos, regardless of their background or socioeconomic status. So as partners in the field of public health, the launch and success of this program are testament to our collective commitment towards achieving universal health care and improving the health and well-being of the Filipinos. So let us take the momentum from today's launch forward as we work together in collaboration with our stakeholders to translate the discussion of today into concrete actions of tomorrow. And let us strive to build a healthcare system that is responsive to the needs of the Filipino people and prepared for the challenges of the future. We also wish to extend our sincerest gratitude to the PIDS for gathering us all today. And once again, would like to congratulate them for the launch of the Health Economics and Finance program. We also thank everyone for attending and participating in today's launch. And we look forward to working with you all as we embark on this journey towards health for all. Thank you and good afternoon.
Okay, thank you very much for those inspiring words, Dr. Bautista. Your insights truly reinforce the importance of our institute and programs work and motivate us to continue pushing for meaningful health reforms. Now, before we finally end, may we just request everyone's participation for the photo documentation of this milestone. So this includes everyone. So if we can request the people at the back to move for the bit, and then our camera will be here. May we request your most beautiful smiles for this momentous occasion. Can we request everyone to please stand so you can be seen better in the picture? All right. May we request everyone to smile in 3, 2, 1. All right. Can we have another one in 3, 2, 1? Thank Right. So once again, if you would like to know more about the Institute and the program, please don't forget to follow us on social media. Follow PIDS on Facebook, Twitter, or X, and on YouTube for the latest updates and events of the Institute. As a matter of fact, we have our next event scheduled on March 27 in celebration of Women's Month. Visit our event page at www.pids.gov.ph/events for more details and this event's registration information.
Now that concludes our event. Thank you very much, everyone, for attending the launch. We truly appreciate you all for taking some time off your day to attend this event. Lunch will now be served momentarily to all our tables, so please indulge yourselves with the delicious meal that Makati Diamond Residences has prepared for all of us.
Once again, I am your host, Dr. Chanel Dayan Mirafuentes.
And I am Louis Ear Dagoy. Thank you very much and have a great lunch, everybody.